Thank you, Dr. Opitz, Dr. Kreisel, members of the association. I feel wholly unqualified to speak on this topic in this city to this audience, so please bear with me. These are my disclosures. So as we heard earlier today, donation after circulatory death is the single biggest opportunity to expand the gift of lung transplantation. These are data from UNOS OPTN published in the American Journal of Transplantation from a few years ago. And when we look in the graph on the left side, number of transplants on the y-axis, years on the x-axis, as a whole, we have seen an uptick in donation after circulatory death in all solid organ transplantation, but when we look in lung transplantation on the bottom right, we've been very static. Now, these data are through 2020, and there's been a recent uptick, as Dr. Hartwig mentioned earlier today, but nevertheless, we are falling behind from our abdominal colleagues. Part of the challenge with DCD recoveries is that in general, it's an uncontrolled death process, and as Dr. Kreisel mentioned, the times around functional warm ischemia are highly variable. And so when you see on the two graphs on the left, these are data from ROPO. We've had 7 candidate donors that underwent withdrawal of life support. 4 progressed, 3 did not. And you see a large variability in hypoxia in the top graph, large variability in mean arterial pressure in the bottom graph. And the result of this variation is that there are disruption in the endothelial epithelial barriers in the capillaries and in the alveoli, leading to changes in gap duct junction, cellular debris and fluid extravasating into the interstitium, and then this priming the organ for reperfusion injury, where we look at a decrease in ATP production in the mitochondria and an increase in reactive oxygen species. Dr. Boba, who's now at University of Florida, when he was with us, with Dr. Ganapathy, looked at changes in DCD allocation over time and looking at 15 years of UNOS OPTN data and seeing that there has been some uptick, mostly regional, but not quite as adopted as we had wanted. So set this as the stage for DCD being the utilization to increase transplantation and also moving this into ex vivo lung perfusion. So how can we do this? As we've heard earlier today, EVLP is a great way to expand the donor pool as an assessment tool, and I'm very briefly going to go through some of the data that I think we're all familiar with, but then focus the last bit on future state. So from the landmark article from the Toronto group in New England Journal of Medicine in 2011, we saw that a marked increase in FPDF ratio in lungs that underwent EVLP for 4 hours were able to go on to safely be transplanted, and compared to their standard control group had excellent outcomes. This was followed by the 12-month survival in the Novell trial, where looking at EVLP versus cold static preservation in an ISHLT control at the time, essentially superimposable curves. We were fortunate enough a few years ago to get a much larger experience from the University of Toronto group of 706 recipients, I believe, and we look at survival from lack of death or retransplant on the left graft, freedom from CLAD on the right graft, no change at all using the EVLP donors, and perhaps a decrease in CLAD. So maybe some change in our long-term immunologic function as we're getting better allografts going at the time of transplantation. Now, those data we're using an acellular technique, and so in order to present equipoise, there's some data around the transmedics or the cellular OCS solution. So these are data from INSPIRE, as I think most of us are familiar with, taking healthy or non-injured lungs, perfusing them, and taking them out to transplantation. So proof of concept, we're again seeing that there are no differences in long-term survival and potentially better PGT rates with ex vivo perfused lungs. This was then followed by the EXPAND trial. We're taking extended criteria donors and comparing them again to cold static preservation. See an increase in oxygenation, decrease in pulmonary vascular resistance, and over time there is no change in long-term survival for both 30 days, 6 months, and 12 years. We've seen regionalization mostly this case report that was in American Journal of Transplantation from a few years ago, again with the Toronto group, where we're able to take donor lungs, resuscitate them, and send them across continent. To me, this is really the demonstration of what a regionalization or a true integrated network might look like from this case study, and this is happening in some degree now currently. This is recently published in JTCVS on behalf of the Novell trial. So we went back and looked at long-term outcomes in brain-dead donor cohort, EVLP for brain-dead donor and EVLP for DCD recoveries. And at 3.5 years of follow-up, again, superimposable survival curves. We look at the physiologic data on the EVLP machine and the bar graphs on the right for those organs that were transplanted, whether they are from DCD or BDD donors. Consistent increase in P/F ratio over time, consistent increase in compliance, decrease in pulmonary artery pressure, so the things that we would expect. But this, to me, demonstrates ability to do this at scale across a country of 17 centers. So I think all this in summary says that, yes, this works. And I put this picture on here thinking that we're on this precipice for EVLP, and I think we probably I should have put a different picture where we're at the base of a mountain going up, because I think the next 5 years we're going to see a lot of advances in EVLP that are going to be pretty astonishing. So I think that all comes around being able to use EVLP as a way to assess organ function beyond P/F ratio. Good metric, but it's not the only metric. We can utilize different ways of mitigating organ injury and then really modifying the organ. So multiple different technologies, multiple different protocols, and I won't belabor that except for some commentary on blood here in a second. So this was a nice review by Ponsholzer in Frontiers in Immunology from this year, looking at really 5 impacts of lung allograft on EVLP. But one of the things that they spent some time focusing on, and I think it's really underappreciated, at least in the lung transplantation world, is this concept of ferroptosis. So cellular, free cellular hemoglobin that leaches out into the intravascular space, or that's in the perfusate. It undergoes the Fenton reaction, undergoes lipoperoxidation and autooxidation, so that when the lung gets reperfused, either on the EVLP machine or in the recipient, you get a large amount of increased reactive oxygen species and ferroptosis. And this drives, I think, a lot of our injury that we're seeing and maybe some of the differences. I think it was commented on with the group from Duke talking about the hemolysis with roller pumps inherent with blood-based perfusates. So one way to mitigate this, and this is some work that we're working with chemical molecular engineer Dr. Andre Palmer, is using polymerized cell-free hemoglobin. So the red blood cells are lysed. They're polymerized to be about 60 times the size of a hemoglobin molecule. And we do benchtop perfusions with, in rat EVLP with red cells or with the polyhemoglobin. We're able to see on a couple of things that to us are quite, have potential for the future. So in the top graph, looking at pulmonary vascular resistance over time, the red is the red blood cell, the blue is the polymerized hemoglobin. See a marked increase in pulmonary vascular resistance over 2-hour perfusion with red cells. A lot of this is from hemolysis. We look at wet to dry ratio. It's preserved with the polyhemoglobin, which also acts as an osmotic agent to pull fluid out of the interstitial space in the perfusate. But I think one of the things that's really cemented this to me as we look at the micrograph at the iron staining, Prussian blue in the bottom, looking at the amount of iron that is in the tissue from the polymerized hemoglobin on the left, controlled, which is an acellular stain-like solution in the middle, and then polymerized, or then red blood cells on the right, is that we're really not getting that hemoglobin leaching out, and have some. Hopefully next year we'll be able to share with you some data of using this in porcine model. So these may mitigate some of the things we're seeing around ferroptosis and ferroptosis in the near future. I think the other part that we'll be able to see, and this dovetails a little bit off of the 10 degrees centigrade part, but preservation of mitochondrial function and energetics. I think when we get the organs normothermic, provide them the appropriate nutrients, these lungs will be more resistant to reperfusion injury in the first few days of potential graft dysfunction. One way in which that might happen is having endothelial or epithelial cell repair molecules. So this was some work that was presented yesterday at the General Thoracic Biology Club. Conceptually, when you have an ischemic injury on the left, you get some disruption of the barrier functions, the endothelial epithelial cell breakdown, and so be able to deliver a membrane repair molecule, such as in this case MG53, which is a skeletal muscle protein, can repair those cell functions and lead to less tissue edema on reperfusion. There are novel ways of assessing organ quality. I mentioned earlier that PDF ratio may be a little bit antiquated, so this is some work that we've published in using impedance as a way to assess for extravascular water in the lung allograft. And similar concept is to standing on your scale in the morning, get your degree of free water in the or extravascular water in the lung, and it does have good correlation. Similar techniques and things have been used by others with ultrasound and other point-of-care methods. So not unique to this, but being a little more sophisticated beyond PDF ratio and how we assess the organs will help us, and we're able to do that on EVLP. Our long-term perfusion of reality, and originally sort of conceptualized back in 1935 with Carell and Lindbergh, but we were there. So again, groundbreaking work from the Toronto group published 2 years ago, looking at cyclical EVLP. And this is very important when we start getting into gene delivery and transfection of organs to make them more resistant to ischemic perfusion, to promote or secrete anti-inflammatory cytokines, and potentially changing them with a potentially a CRISPR level of delivering their own immunosuppression to the organ. So these things take time to have take effect into the organ, and as we're able to see here from the work by Seppel and others, 72 hours is achievable, and so we're getting to that point. How do we decide which donor, all these different metrics? It's information overload a lot of times. A lot of this information is beamed directly to your phone. Using novel methods of artificial intelligence to take physiologic and donor data and integrate it at a way in which we aren't able to do with our normal nomograms. It's coming. It's published again by the Toronto group, Sage et al. The descriptive ability to predict primary graft dysfunction at 72 hours is quite good. And so we start to see this rolling out at scale, particularly at larger centers. It may help us decide when to transplant and when not to, as we aggregate a lot of this data that are coming off of the machines that we just don't have the ability to process as humans. And then this next bit is very sci-fi. So when we start getting into decellularization and recellularization, this was published earlier this month in the Nature Scientific Reports by Toyama in Japan, and taking a mouse lung, decellularizing it, recellularizing it on an ex vivo perfusion circuit, and taking it on to transplant, we're really able to build those lungs. And I think this technology, coupled with some of the work from Revivicor and United Therapeutics around genetically modified pigs, we're going to get to that point where we're having a modified organ that is recovered from a porcine backbone, may be decellularized and recellularized with human cells, and then going on to transplant. The amount of work that is happening in this space, to me, is mind-blowing, and I tried to summarize it here, but we've got pig kidneys going in patients who have undergone ventricular assist device placement. We've got modified porcine hearts. Revivicor getting a $100 million disease pathogen-free farm that just opened up in Southern Virginia. So this is coming. And then they're genetically engineering some of the kidneys with the euthymic kidney, they're calling it, where they've CRISPR'd in the thymus in the kidney capsule so that when the kidney is transplanted, it's able to precondition or ongoing condition the recipient to not have graft versus host or host versus graft rejection. So this conceptually, if this works, since they just did this first transplant, we'll see how it happens, maybe coming to other organs as well. So lung is still a far way off, but it's rapidly approaching. And I think the thing that maybe the transition or the segue for people is this concept that was just done in China, where they put a pig liver into a person for 10 days and used it to detoxify the recipient and wait for an organ to go into transplantation. So we may find a time where we are using porcine lungs that may be reconditioned or assessed on EVLP platforms as a bridge to transplantation and waiting for human allograft. So next 5 years will be very interesting for sure. So in summary, DCD is the biggest opportunity to expand lung transplantation. I think we're all in acknowledgement of that. Ex vivo perfusion may expand the potential for the donor pool and allow for functional improvement, removing cytokines, preconditioning, and I think very most importantly, avoiding plasma-free hemoglobin. And we're just beginning to realize how these changes are going to impact the EVLP field. So with that, I thank you for your time.